Good morning, everyone. I think we're going to go ahead and get started. I know that folks are still joining us and will continue to join us across the next few hours, but we are eager to get going. I'd like to extend a huge welcome to NYU's first Community Health Worker Innovation Summit, titled Making Models Last, Current and Future Sustainability for the Community Health Worker Workforce. We are just truly thrilled today to have you join us from really all across the country for what promises to be a really insightful and we hope engaging discussion. We're especially delighted that today's audience includes so many community health workers, over 120 from all across the country, along with CHW advocates, representatives from health systems and the public health sector, community-based organizations, and researchers. For those of us who have had the pleasure of engaging with CHWs, we're keenly aware, particularly against the backdrop of a devastating global pandemic and ever-widening disparities in health, that there's really no more important time than now to consider how to ensure the durability and sustainability of this workforce. So a little bit about myself and the organizers of this event. My name is Nadia, and I'm an associate professor at the NYU Grossman School of Medicine in the Department of Population Health. With colleagues, I co-direct the Community Health Worker Research and Resource Center, or the CHWRRC, and the NYU CUNY Prevention Research Center. Both are co-sponsors of today's summit. The CHWRRC is housed within the Department of Population Health and supported by our institution's community service plan. We launched the RRC in 2018 to really bring together NYU's extensive and growing CHW workforce, but also the CHW related knowledge and expertise that we've been able to garner across our institution to really strengthen and support this workforce, reduce health inequities, and also recognize and help build community capacity and leadership, which is really at the heart of the CHW model. We accomplish this through two key strategies. First, guided by CHW leadership, we foster a peer support and professional development network for CHWs across our institution. And second, we provide training, technical assistance, and evaluation expertise to established and emerging CHW initiatives. Our CHWRC works closely with our NYU CUNY Prevention Research Center, which is part of a CDC-funded network of PRCs across the country. Our PRC, NYU CUNY, has a specific mission of generating the evidence for sustainable and scalable community clinical linkage strategies, including CHW approaches. So I have the pleasure today of moderating our first panel, which we've called Dollars and Cents, Current Trends in CHW Payment Models. I'm going to take a few moments to introduce our esteemed panelists and then really dive right into the program. We're going to just begin our discussion today with a dialogue between myself and Dr. Sarah Redding, who directs the really innovative Pathways Community Hub Institute, or PCHI. PCHI is a nonprofit that was established in 2015 to support the nationally certified Pathways Community Hub model that Dr. Redding and her colleagues developed, and really has community health workers at its core. Dr. Redding has been involved with building new strategies to provide community-based care coordination, including training community health workers over the past 25 years. And Dr. Redding has co-founded the Pathways and Pathways Community Hub models with her husband, Mark, and their focus has really always been on improving health equity. This will be followed, so the discussion between Dr. Redding and I will be followed by a panel discussion with representatives from payer and community-based organizations that have invested in the CHW workforce, including Dr. Susan Beane, Dr. David Ackman, and Ms. Shoshanah Brown. I'm going to briefly introduce each of them now, and then we will move on to their panel after the discussion between Dr. Redding and I. So Dr. Susan Beane is the Vice President and Executive Medical Director at Healthfirst and focuses on care management and clinical provider partnerships. She really leads Healthfirst in collaborating with major healthcare delivery systems, local and national policy experts on the design and implementation of really outcomes-focused models of care. Prior to joining Healthfirst, Dr. Beane served as the Chief Medical Officer for Affinity Health Plan. Dr. Beane will be followed by Dr. David Ackman, who's the Chief Medical Officer for Empire BlueCross BlueShield HealthPlus. He came to Empire after helping start HealthPlus's Medicare Special Needs Plan and has also served as Medical Director of the Sunset Park Family Health Center Network, as well as the Ambulatory Care Network for New York Presbyterian Hospital, two of the largest safety net ambulatory networks in the country. And finally, we'll hear from Ms. Shoshanah Brown, who is the founder and CEO of AirNYC, a community-based health justice organization with roots in a Harlem-based research project focused on Black and Latinx children with asthma. During the 11 years that Shoshanah has led the organization, AirNYC has really become the go-to tech-enabled workforce partner for providers, a host of payers, and people working to address the social drivers of health with a whole person approach. Headquartered in the Bronx, AirNYC's community health workers meet families where they live to improve health and avoid traumatic hospitalization. So you can already tell that this is going to be a really exceptional discussion and panel. I've been eagerly waiting to have this discussion with everybody today. Just a few housekeeping logistics before we get started. Please do type your questions in the Q&A box, not in the chat function. Panelists are able to chat, but we do ask that if you have questions for the panelists, please post them in the Q&A box. We'll collect and save them for the Q&A portion, which we'll hold until the very end of the panel. At the end of this session, there will be a pop-up poll with a few questions regarding today's event. You'll also be receiving a slightly longer evaluation on the entire Innovation Summit in your email. We do ask that you just take those few moments to answer the poll and subsequently the survey. It's really going to be helpful to us in planning future events. And then finally, we hope you can, just a reminder that this is a 2-day Innovation Summit. We hope you can join us for day 2 tomorrow, which begins at 10:30 Eastern Time. If you haven't registered for day 2, there is a link that we'll post in the Q&A box. So with that, I think we can get started. Dr. Redding, welcome and thank you for joining us. So to begin with, we'd love it if you could tell us about the Pathways Hub model.
Thank you. I'd be happy to. So our story actually begins, and it's definitely Mark was as much a developer of this model as I was, in Alaska. So we're both physicians. Early in our career, we spent 3 years in Kotzebue, Alaska. And that's where we first met community health workers. Had never heard of them before, had no idea what to do with them once we got there. But they became such an important part of our medical team, especially in such a remote and isolated area. So our little hospital serviced an area about the size of the state of Michigan. There were 11 villages that had clinics that were staffed and run by community health workers, and they just did amazing work. We left Alaska and went to Baltimore to finish our training, and I was fortunate enough to work with community health workers in Baltimore City. They were funded through a federal grant program, and unfortunately, I also got to watch what happened when the grant ended, and they were all let go. So all of those amazing community health workers now were out of a job. So the next slide, as we landed back in Ohio, we were pretty frustrated at that point that, how do you make this work? And we almost gave up, but decided, well, let's give it one more shot. And we started the Community Health Access Project, which was just a small nonprofit, really with the goal of having community health workers in our own county. And we picked high-risk pregnant women to work with. We had no training program, so we partnered with our local community college and developed a really extensive training program that became the model for Ohio's state certification. So Ohio was the second state in the country to certify community health workers. So we had great women hired, we trained them well, we sent them out to work with high-risk pregnant women, and we looked at our data after about 1.5 years and we hadn't budged the numbers. So that was pretty frustrating. But the next slide, we were finally starting to hear what our community health workers have been telling us all along. Kimberly and Juanita and Ruthie were saying, hey, you want us to get them to prenatal appointments, but they don't have transportation, or they don't have housing, or they're in a bad relationship, and we have to deal with those issues first. So the next slide, really, this is where we are today, and it's taken a while, but it's the whole person care approach. But from our model, we look at individually modifiable risk factors. So what are the risk factors that community health workers can truly impact? And that has become a major part of our research. Our most recent publication was in the May 2020 Journal of Preventive Medicine, and it really laid out our risk framework. And I could spend all day talking about that, but I'll leave that for future questions. But the next slide, we had to have a strategy, a better way to be accountable once we identified those risks. And that's where the pathways approach evolved. So a pathway is simply a tool that measures each individually modifiable risk factor from identification to elimination. So on the slide, you have an example of the medical home pathway. And this is really started when the community health worker finds somebody who doesn't have a place to go for ongoing primary care. But the pathway is not closed as complete until that individual has shown up for the appointment and done everything they need to do to be enrolled as a patient in that place of care. So also in our model, we tie payment to completed pathways. So it's an outcome-based model. We've learned from using pathways that very often we can't get to the outcome that we want, and we have to close a pathway as a finished and complete pathway. But what we've learned over time is that we get a lot of information from those pathways about what doesn't work in the community or what barriers still persist. The next slide is just a little snapshot of how we do our outcome-based contracting. So we, in Ohio, in Wisconsin, in Texas, hubs have partnered with Medicaid managed care payers, and we have a standard approach to develop those contracts. So we have codes and modifiers, and we can talk the language of a payer, which is really important. We've also developed what are called outcome-based units. So for a new hub that develops and doesn't have the experience of how much effort it takes to, let's say, complete an adult education pathway, we've developed a guide through the outcome-based units. The next slide is a listing of our 21 standard pathways, and we've been able to cover newborns through elders with these pathways. So far, we have not been stumped yet, but we're always willing to innovate and add new pathways. We're actually going through an update to the model in 2021, where we retired 4 of the pathways and added 5 new ones, but this is our current list. The next slide shows some of our early published results. So this was when we started using pathways just within our own organization, CHAP. And again, we were working with high-risk pregnant women. We gave 4 years of our data to the Ohio Department of Health, and they matched to vital statistics. And then that data set was given to the Ohio State University Department of Biostatistics. They did a case match control by census tract, so really trying to compare women living in the same neighborhood. What the data showed is that over those 4 years, if women were working with our community health workers and using the pathways approach, the low birth weight rate was 6.1% compared to 13%. Now, everyone jumped to the conclusion that it was all related to better health care, but what we were able to show is that there was no significant difference in entry into care or utilization of prenatal care. But what we could tell from our community health workers and the work with their participants is that on average, women had 5 additional pathways, and none of those were health pathways. They were related to employment, transportation, housing, all of the things that community health workers excel at. The next slide is where we are today. I could spend a lot of time talking about the development from an agency to a hub, but what we realized as we started to see the results is that we would never impact health disparities through one agency, one organization. We needed to reach out to the larger community. And that's where the Pathways Community Hub model evolved from. We sought partners that were working with the same high-risk population, and we engaged them to use the same Pathways strategy. So where the Pathways Community Hub model is now, you can see in the center, the PCH stands for the hub, but the largest visual on this slide is the community health worker and the family that they work with. Whatever we do in the model, we do not want to disrupt that relationship. We want to do everything we can to support it. The hub itself is a very small organization, and it's neutral. It doesn't employ community health workers. What the hub does is reach out to all of the agencies and organizations that already exist in a community and contract with them and with their community health workforce to do this care coordination work. So it's really building on what the community already has in place. So the hub is responsible for helping with training and with quality improvement, but a big job of the hub is to go out and find funders who are willing to pay for pathways. And those funders can be health plans, they can be local or state government, private philanthropy, United Way. We have a variety of funders that support hubs right now. It's important in a hub network to have referral partners. So those are those agencies and organizations that are out in the community that can identify people at risk and refer into the hub early on. And also our direct service providers. So, when we make a referral for healthcare or for behavioral health or housing services, we have to have strong community linkages there as well. The next slide shows that we have developed a national certification for this model. It was something that we learned in our work with the Agency for Healthcare Research and Quality. The model was picked as the first one under the Innovation Exchange. And we worked with many communities over a span of 4 years. But what we found is you really needed to have all of the essential parts of the model. So the certification program has been developed. As of Monday, we have 17 certified Pathways Community Hubs. Most of those are in Ohio. That's where the model evolved, but also Washington, Wisconsin, Michigan, and Texas. I would like to highlight that in Ohio, one of our major champions has been the Ohio Commission on Minority Health. They embraced this model early on as a way to get to health equity, and they have worked very hard to obtain funding for replication and expansion in Ohio of the model. We hope to be up to 11 hubs next year and cover probably about 75% of the state. The next slide is just a screenshot of our website, pchi-hub.com. I know I'm giving you a lot of information, but if you're interested in the model, this is where you can go to click on an interactive map and find where hubs are and reach out to those hub directors. Also, all of our research publications are under resources. And the next slide, because this is all about workforce development and sustainability, I wanted to give you a little bit of information that's kind of old now. It's 2018 when we only had 5 hubs in Ohio. But at that point in time, we had 125 full-time community health workers working within hub networks. Over 50% represented minority groups. 40% of those community health workers were unemployed before joining an agency supported by the hub. And about 10% were former hub participants. So that was really exciting to see. But as I end, kind of as in the beginning with the next slide, it's really all about the relationships that you build with your participants. And this model is all about trying to support and sustain the amazing work that you do. So thank you.
Thank you, Dr. Renning. It was so helpful to understand how this model works and really to see the evolution of the program. And I think so many of us are very familiar with where you were in Baltimore, having a grant-funded CHW program that was hugely successful. You've built the capacity of these incredible community leaders, and then it has to end. So I think this is why we made payment a central part of today's discussion. And you've described to us how the work is paid for. What were some of the kind of challenges and opportunities you discovered along the way in developing those payment models and figuring out how to keep this program going?
Yeah, oh, so many challenges along the way. But in the beginning, so our first contract with a Medicaid managed care plan was in 2007 with Centene. And, you know, they wanted to pay for health pathways. They really didn't get the message that all of these other things mattered. You know, housing mattered and having food security mattered. And it took a lot of years of us just doing the work and collecting the data to show them, you know, over time, yeah, you're seeing these good outcomes, but we really believe it's because of this work that's happening. Not that connecting to medical care is not important, but it's just part of the picture. And so over time, they've kind of come to embrace that. So now our contracts actually with all of the major payers in Ohio cover all of the pathways and cover all populations. So it's been a long journey to get there and a lot of sharing the data. And that's really important. You have to have that data to share. And it's hard to collect sometimes, you know, when you're working in a community setting.
That's great. So let's talk about data and evidence for a moment. And I have sort of two questions along this line. First, I was really struck by your comment that, you know, for the pathways that aren't completed, those kind of gaps in service that you see, there's a lot that you can learn from that. And so could you talk a little bit about how you use those findings and data to inform your work subsequently?
Sure. So the neat thing with hubs is they're a very cooperative, collaborative group. So in Ohio, again, all of our hubs in Ohio work with high-risk pregnant women. We were able to pull our data together around housing for high-risk pregnant women and show our state legislators that we really couldn't get women housed. And so there was a policy change at the state level based on that, you know, those finished and complete pathways, those pathways that couldn't get to the outcome. So there's a lot of power behind that. It's solid data that you can't just ignore.
Great. And then, you know, I think for many of us in the audience, and I can see some of the comments in the chat, we're really heartened to see so many pathways are about social needs outcomes. And I think it's really inspiring to know that, you know, payers were engaged in paying for those outcomes. So just to push that a little bit further, you know, so much of the evidence on CHW impact has focused on health outcomes, utilization. Your program has demonstrated and is able to get reimbursement for social needs. But we also know that CHWs may have a really strong impact on things like social support, on building community, on enhancing self-efficacy. Do you see any potential opportunities to convince payers or other stakeholders that these are outcomes that are worth investing in?
I really hope so. I mean, I think we went to where the most of the money is, which is healthcare right now, right? So I feel there's a lot more work to do. We're happy to be where we are now, but there is a lot more to do. And you're absolutely right. There's so much more that community health workers do beyond just health outcomes. How we get there, I don't think we figured that out yet.
Yeah. And maybe this is a question we can come back to with other panelists as well. You talked a little bit about the scalability of the Pathways Hub model, and it's in, I think, 17 different locations across the US. Maybe that was only Ohio. Can you tell us a little bit about what it took, you know, to scale this program? And, you know, I know we had a discussion yesterday, and part of what I found very interesting was, you know, you've sort of created a template for contracts with payers, which I think is probably very helpful. And I'm sure there's other pieces that have really supported replication. So can you speak to that?
Yeah, and that's really why we developed the certification model, because there are key elements that have to be there. That outcome-based payment, the community health workers supported by strong supervision, all of those really important pieces are in our prerequisites and standards, and why we encourage hubs to become certified. And in Ohio, actually now, our payers will only contract with a certified hub because, again, there's fidelity to that model, right? We've seen what happens when you only use pieces and parts of a model. It doesn't get to the same outcome. So that was our approach to try to help a new community. It's kind of the roadmap for a new community looking at the model. Pick up the prerequisites and standards, understand those, and then reach out and get help to build a hub within your own community. I will say hubs work really well in collaborative communities. So that's kind of like a precursor to building a hub, is you already have to have strong collaboration.
Mm-hmm. And the actual hub, is that, for in places where the program has been scaled, is it something that's already in place, or do you build the hub? I know you mentioned that, you know, building off of collaborations is important, but is that something that you develop in your new locations?
Say the beginning part of that again. I think I just missed the...
Just the actual hub, is that something that's created new in the kind of
so
location?
who is the hub in a location?
Exactly.
So that's really up to the community. So sometimes they do develop a new agency because they don't have anybody who could be neutral. But sometimes there's a really good organization that's there that can take on that role. We just have a whole variety of, you know, in some communities it's United Way. There's a health department that's a hub, quite a few community-based organizations. So it really depends on what that community is comfortable with.
That's great. And you mentioned that the hub is generally, it's not a huge team, you know, it's a small team. Can you tell us a little bit about who makes up the hub, and, you know, what kind of skills and expertise are needed for that kind of infrastructure piece?
Sure. So you have to have a hub director, and that person really needs good business skills, right? Because they're the public face of the hub. They're out contracting with the care coordination agencies that employ the CHWs, but they're also contracting with payers that are going to support the hub. So they really have to have a lot of skill sets more on the business side than healthcare or social services. You need to have somebody who's kind of based in the office that can troubleshoot for community health workers, you know, as things come up or as referrals come in. So somebody who's really based there, you know, 8 to 5. And then somebody who's looking at the quality. So that's analyzing the data that's coming in and saying, oh, we have a problem here, or we're doing really well here, but let's go retrain. So those are like the 3 key people you need to have to start out. And then it's really just based on how your hub grows. If you grow into a large hub that has 25, 30 agencies connected to it, then you're going to have to add staff to help support those positions.
And is there a standardized data platform that you use for this integration, or do you really rely on the kind of local area to develop or leverage something?
Well, we made the decision to not be like a technology provider. We're really just focused on the fidelity of the model, but what we have implemented is a certification for technology vendors. So vendors that support Pathways Community Hubs need to go through and prove that they can actually do what a hub would require them to do. So this is new for us, and we have several vendors that are going through that process now, but we will just, as a vendor becomes certified, we'll put it on our website. So as a hub is starting out, they can go to a kind of a, you know, an approved list of vendors that we know will be able to support them.
Right. I'm gonna, for our discussion, I'm gonna leave you with one last question, and then I think I'd like to invite the panelists to join us. You know, I think we've seen what a crucial role CHWs play during the pandemic. I think it's been highlighted in so many different forums, in the media, in kind of the literature on CHWs, and really at the grassroots community level. I think CHWs were very early on identifying and serving and connecting community members who were otherwise very much disconnected. How do you think the Pathways model could leverage some of the current efforts as well as funding mechanisms involving CHWs, such as contact tracing for COVID, or other efforts that are really engaged in, improving COVID-19 related outcomes?
Yeah, I think we've seen all the hubs step up during this pandemic. Some are much more engaged by health departments than others. I would highlight the hubs out in Washington State as working really strongly with their health departments. But all hubs are providing support, especially to the folks that, to be able to stay at home and to not be out, if they're quarantined, to be able to get supplies that they need and to get the support that they need. I mean, that's where we've seen CHWs really step up to kind of the hardest to serve people during the pandemic.
Yeah, absolutely. And I think some of those pathways that you've identified, we've seen are some of the really primary issues that have come to the forefront during the pandemic in terms of food insecurity, employment, housing, et cetera. Wonderful. Well, thank you, Dr. Redding, for this conversation. And I do invite you to stay with us as we transition to the panel. And I'd like to now invite Drs. Beane, Ackman, and Ms. Brown to join us. Each of our panelists will be providing a brief overview of how they've engaged the CHW workforce in their efforts. And then we'll have a kind of moderated discussion with Dr. Redding, Dr. Beane, Dr. Ackman, and Ms. Brown. And at that point, we will also open it up to the audience for Q&A. So I'd like to invite Dr. Beane to get us started.
Sure. Well, thank you so much for this invitation. This is a topic that is near and dear to our hearts at Healthfirst, largely because of our opportunity to actually work with the NYU CUNY PRC some years ago. So let me share for a few moments what we have been working on and some of our thoughts. Next slide. So what I would say is that we have actually been interested in navigation and coaching models since about 2016. I'll describe some of that journey to you. You can see it is in very tiny font. And that's because we are still learning and still, doing proof of concept and trying to figure out how a CHW model can fit into a delivery system based in New York. Next. So just to sort of highlight some of the milestones for us is that our work with the New York State AIDS Institute, which has funded managed care organizations to be part of ending the epidemic, sort of made us think more seriously about whether or not we could engage our members who need us through peers or navigators or coaches or CHWs. This is an evolving model with a lot of tiny font here. But I think if you can sort of focus as you go down this logic model, you'll see a little red box that says unaligned, and you'll see a green box that says aligned. And this became the centerpiece of our approach on a population level to community health workers. Remember that there are lots of models. Dr. Redding described one important model. This is a model that is attempting to move health outcomes for high-risk populations in our New York City region. And so you can see that we have a real focus in managed care, and Dr. Ackman will say the same thing, on primary care. That's the centerpiece of how we work. And so most of the work that we have done is trying to figure out what keeps members in a trusted relationship and what might be a barrier to that. Next. And this is the model that we think about. We are always working to have something for all of our members. And this model shows the continuum of what we have available. Some of you may know that Healthfirst is a value-based model, so that most of our PCPs, most of our members are in a setting that's influenced by some value-based contracting. So the gray just shows that where members have a trusted PCP and few barriers, we really focus on quality and the pop health kinds of interventions that we're all used to. Those members do quite well. and are often able to overcome barriers themselves as they work with their PCPs. We take out of that population women who are pregnant and infant health. As you know, New York State, or you may know, New York State has a 1,000 days project that is really taking off, and so we are thinking about them a little bit differently. The orange on the end is traditional case management. And again, David and I have both worked in this industry for a long time. And that's really where our members who are chronically ill but unstable, have disabling conditions, et cetera, are clinically complex, whether they're children or adults, find value through case management. And then the programs I'm going to describe to you, we've been building up in that yellow bar. And these are members that we believe have either an access issue or a social factor that complicates their ability to achieve their best health. Next. And this is kind of how the model looks. There are members in the middle. They look pretty homogeneous, even though they're not. Frankly, it's hard to tell what's really going on in the life of a person, especially when they're only with the clinical system about 20% of the time. And so what you see is we're trying to build around them. And the secret ingredient here is that, you know, if everything was working well, a PCP would be doing a lot of this work if they're structured to do so. But if they're not, we build around these members these various kinds of services. Next. And so along the way, we face the scribble scrabble of managed care. This is where you try to take these poor, unsuspecting members and get them through a door that's going to help them. And often that's scribble scrabble, meaning that it's a manual process. You're sending Excel files, you're sending paper, you're hoping a phone call works. And you can see that our members and PCPs began to describe a lot of different needs that they had. So our programs became much more complex. Next. So we began to think about a digital solution. And our digital solution just allows us to assign, connect, if need be, assess, refer members to various kinds of services that may need, and track the outcomes. So next slide shows you sort of how this is constructed. This is obviously simplified, but not that much. This yellow circle is the digital platform. We want there to be no wrong door for members, so they encounter their community-based organizations in this seamless way, and it allows them to go in and out of different service environments in this circle. So I can actually be a whole person in this circle. I can come in and need help with housing, but also get RNYC to help me with my breathing, and I can also get help with social isolation. So the platform is something we've been really working on to actually see if we can serve members without sort of being kind of a one-off on everything. Next. We don't specifically do an SDOH assessment. We count on our partners to do that, and they each have their secret sauce. But we do what we call a patient perception of health. This survey sits on our platform. It is how we can begin to ask our members what they would like to have to help them on their health journey. They consent to everything. If they say nothing that you're offering me seems right, we just say that's fine. However, our PCPs and specialists actually created this as an evidence-based model, and we have used it for a number of years. Next. And so this allows us to sort of track and then measure outcome and the value. So I know that's a big deal today. I will say that our model is generally funded through medical expense for the kinds of services that these organizations are rendering for us. The CHWs do not work for Healthfirst. They are all employed by our organization partners. It's not a perfect model, but what we have found is that we can begin to together think about whether members are choosing to find out what they could use through that survey, closing gaps in care, whether members choose that agency to help them with social service needs, then how much they navigate in between CBOs and also clinical care, and then finally, ultimately, do the members align with a trusted PCP? I think that's my last slide. Yes. So thank you for this opportunity and glad to take questions and participate with my esteemed panel members.
Great, thank you, Susan. And we will move on to Dr. Ackman, who will tell us about efforts at Empire BlueCross BlueShield HealthPlus.
Well, thank you, and thank you for inviting me to participate. Susan's provided a terrific lead into how the role of managed care companies in this sort of activity. I just want to give you a little context. Empire BlueCross BlueShield is a 450,000 member plan operating in New York City and the surrounding counties, ensuring Medicaid, CHIP, and managed long-term care recipients. We are part of Anthem, which is the second largest for-profit insurance company in the country, insuring, I think, just under 40 million people, operating in about 25 different states. But each of the plans within the Anthem universe is somewhat autonomous. And in this particular activity, community health workers, it really has been a homegrown effort. All Medicaid managed care companies in New York State provide a variety of services to help members access care and also obtain community and government services to help them manage their health. Most of that is through programs in physical health, and there we have community health workers and disease management programs. And in behavioral health, where we have a very resource-intensive and well-developed program to help manage and support people with serious and persistent mental illness. The community health worker program was developed to sort of be across both of those, but without such a clinical focus and more of a supportive and a community-based focus. We started our program in 2016 when we tapped about 18 people who were working in retention and outreach, basically people who were doing a combination of marketing, sales, and retention to become community health workers. We brought them through training provided by the Community Health Worker Network of New York City. We selected them because they, for a variety, to cover a variety of languages, ethnicities, races, and communities in New York, so that we would have people who were already connected with different neighborhoods, new people, and were known in those neighborhoods. And what we wanted them to be is really be intertwined with the operations of the plan. That is, we didn't want this to be a one-off. We wanted them to support really what the plan's goals were, which were a combination of improving quality, improving member experience, but also creating a return on investment. That is, we wanted to demonstrate that the community health workers not only sort of could improve access to care, but would also reduce expense or increase revenue for the plan, which I think is something particularly important in a for-profit company. So over the last 4 years, we've gone through a series of iterations with this program, primarily because we've changed how we've selected members to be outreach and included in the program. The first effort was with highly complex, high cost members that were selected through a predictive algorithm we run at Anthem called the CI3 list. It basically is predictive of future medical costs. And the thought was that we would use community health workers in combination with caseworkers to try to prevent hospitalizations and better connect them to care. And that effort was, I think, not very successful. I think the community health workers didn't add a lot to what was already being done through case management. And so we switched gears, and we then looked at a group of people that we had not really had much contact with. In fact, they had very little contact with the healthcare system at all. Between 15 and 20% of our members in any given year have no contact with the healthcare system. They don't see doctors, they don't fill prescriptions, they have no healthcare needs. And so we wanted them to at least make contact and have a visit with their primary care provider. One, because obviously you have the opportunity to do screening and uncover unrecognized medical conditions, but it also actually in New York's Medicaid program changes the reimbursement for those people. So the premium on them increases if they have contact with the medical system. And so our community health workers, and I didn't do this at first, but our community health workers make initial telephonic contact with members, but then go out and visit them and meet them in their homes or in a community setting. And and they've been able to do that with some measure of success up until obviously the start of the COVID epidemic, at which point we've become totally telephonic. Our engagement rate, that is our contact rate with members over the phone, is probably around 40%, and depending upon the population we're choosing, drops down into the 30s and maybe 20% when we look for ability to enter and see them in their home. So going back to the second project, which was what we call the non-users of medical care, we worked with that population for about 9 months. And then what we found on the evaluation phase was that we really were not driving people into the office. In fact, we found that members that we contacted had about the same utilization of primary care services as people who we were unable to contact. So then we switched to a disease focus, asthma members, and we were able to select for asthmatics people who had made frequent visits to the emergency room and had other measures of uncontrolled asthma. And in this case, we were able to show some better effect, improved effect. We did this, the community health workers received some additional training on asthma management, relating to adherence to treatment, avoiding triggers, obviously compliance and working with their PCPs. And in that, we did show a substantial reduction in both ER visits and an improvement in medication compliance, even above what we were seeing in the control group. And that project is ongoing as we refresh our outreach list to find new members who have asthma. And now we've sort of expanded that into other disease-specific metrics, populations, looking at measures that impact our quality scores and our quality bonuses. So we're looking at working with HIV infected people, who are not getting, either not filling medications or not getting viral load testing. I think what the overall experience has been is that it provides us with an opportunity and a resource and an ability that we didn't have before. And I think the experience of the community health workers themselves has been tremendous. I think they feel that they are truly accomplishing and serving their community. Our ability to demonstrate impact in the way that we have chosen, that is both utilization and cost, has been, I think, more of a mixed bag. So with that, I look forward to answering questions and participating in the discussion.
Wonderful. Thank you, David. And I'm going to move us right along to Shoshanah to hear about the work that she's led at AirNYC, and then we will move into the discussion. Shoshanah.
Great. Good morning, everyone. I'd like to begin by thanking you, Nadia, and NYU for putting this together. It is wonderful to see that we had over 420 people registered this morning. Even if everybody didn't show up, maybe they'll revisit once we send out material. And that is a real step forward in terms of recognition of the importance of community health workers and the value that they provide within the healthcare delivery system and within community, more importantly. So please advance to the next slide. The mission of AirNYC has been from the beginning about community health workers, that it's to meet people where they live, to improve health, and to connect families to social care and build health equity. These are words and phrases and language we're hearing a lot about now, and I think that's awesome. And one of the reasons I'm thrilled that there's a financial dimension to this panel and this discussion today is because I'm eager to see investment commensurate with the discussion, and to see willingness on the part of payers, health systems, states, and government to really put our money where our mouths are in terms of investing in communities. Please advance. Before I get to the history of AirNYC, which I will go through very briefly, I'll just say that I have a background in public health and in business. I was a community health worker. I learned to be a community health worker in a rural village in West Africa, the country of Burkina Faso in particular, where I worked in a community that was without electricity, without running water, where there were no doctors for a population of roughly 20,000 people that all came in when, very late when they needed help to the state-sponsored clinic. And so the importance of going out to the community, to where people lived, and talking to them about barriers to care was very important. And the projects that I worked on there were about access to safe delivery, access to water, basic health education. And although this was many years ago and in another part of the world, the approach and the values are really the same. And what we try to do at AirNYC, and you'll hear a different perspective on community health workers from me and from my team and from the other community health workers on the call than you will, of course, from Drs. Beane and Ackman, or even from people working in academic settings, because we are coming from a different place. And going through sort of like our values and just giving you a sense of what they are. We are community rooted, we are culturally humble, we are data driven, yes, but we are person centered above all. And we are also anti-racist. And that is something that many of us can say, but in practice, we spend a lot of time thinking about what that looks like. And when we say we meet people where they are, we mean that on all the levels. So AirNYC was born out of a participatory, this is always a tongue twister, a community-based participatory research project in Harlem with partners including Harlem Hospital Center, Columbia School of Public Health, Department of Biostats in particular, and Harlem Children's Zone, with the vision of Jeff Canada, who was working at the time in just 24 blocks of Harlem, and recognized that asthma was the #1 reason that his students were missing school and wanted to do something about it. At the time, Harlem Children's Zone didn't have any direct healthcare initiatives. And asthma was the first kind of condition that he rallied around in partnership with Harlem and these others. So in 2000, I've been leading the organization for 11 years, proud to say. And in 2011, we launched the organization that is now AirNYC as a CBO. We moved out of the hospital into community and began building more of an independent workforce and platform so that we could really lead and own our data. I spent probably the first year wrestling with academia to get our data back. Spent that first year really trying to learn how we could be stewards of our own data, how we could develop a balance between clinical and community, between data and service, between research and service. And we really flipped the whole sort of research project on its head while adhering to the fidelity of the value of community health workers. So in this 11 years, we have gone from working in a paper-based world to one where we are, working with data on electronic platforms. We now have partnerships, including with Healthfirst, and Dr. Beane has been a terrific partner, allowing us to innovate together and think about how we really reach people. Please advance to the next slide. I wanted to put Dauda Dirasuba up here. I've worked with Dauda for the last 11 years, but Dauda preceded me when he came to the United States in 1993 to Harlem, where he still lives. And he really embodies everything that we're trying to build. He knows the community. He speaks Mandingo, French, and English. He brings the empathy. He brings the connection because people don't think of themselves as an AMR score or as a high utilizer. They think of themselves as people with lots of different barriers to health, most of them social. And so working with someone like Dauda has been a real privilege, an honor, and it's really, again, what this workforce is all about. Next slide, please. I'm getting a cue that I have to talk faster, so I will talk faster. Next slide. Thank you.
I think you're doing fine.
All of this is, all of our growth and all of our, attempt towards sustainability has really rested on our ability to show our partners that we are in fact having an impact on reduction in emergency department visits, reduction in hospital admissions, reduction in the mean length of stay. This is validated data that came out of the work we did with Medicaid redesign here in New York City. And before I am sort of kicked off the panel and run out of time, I just need to say a few more things. We do understand the need to work with data. One of my concerns, and that I'm going to make some trouble on this call, and hopefully it'll be good trouble, considering that one of my partners is here on the panel with me. One of the concerns right now is that the responsibility to work on multiple data platforms and the lack of interoperability is really cutting in to what the whole community health worker framework and mindset should be about. We are now spending up to 3 hours a day managing data rather than engaging people. And when I hire community health workers, when my team recruits, we are looking for people who connect with people. Yes, they need to be able to manage data, but we have to, really consider what we are losing when we overwhelm our community health workers with data collection. It also flips the dynamic in a detrimental way toward collecting and taking from people rather than providing a service, promoting change and inspiring and motivating people to make the changes that we all want to see so people can be healthier. So I imagine that I am out of time. I definitely have more to say. I am above all really just more than heartened to see this kind of conversation going on. Funding is still really challenging. There are still so many pilots and so much pressure to develop proof of concepts along the kind of axis of ROI. When we know there's value and we know there's return on investment, we need to redefine those metrics. And we really need to think about how to lift up this workforce, which is so valuable, powerful, and desperately needed in the United States.
Thank you, Shoshanah, and I hope you get a chance to see the chat and the sort of string of amens as you were speaking. So I think there's a lot of empathy and agreement and shared frustration that would be really helpful to kind of talk through, I think, during this panel. So I'm gonna take my moderator's prerogative. Of course, I have millions of questions myself. There are many questions from the audience as well. So I'm gonna do my best in balancing the two. But I wanna start with, Shoshanah, something that you kind of ended with and you know, was, I think, highlighted in all of our speakers' presentations. And that is this question about return on investment. I think the CHW workforce in both research and policy discussions, you know, is really consistently forced to prove their ROI. But if we think about other healthcare workforces, we don't often ask the same thing. We don't often ask them to prove their ROI, to justify their merits. So, you know, what are each of your thoughts on other ways to make the case for value for community health workers that doesn't define success as reduction in medical costs? I think Dr. Redding provided us with some good examples of that, but it would be great to hear from both Sarah as well as others. And this, I think broadly, we'd like to hear your perspective on why you think there has been this reluctance to kind of support and acknowledge the CHW workforce. So anybody is welcome to jump in, or I can just choose you. Does anyone want to jump in?
Sure, I'll be bold, and I know David was going to go, but I'll go first. This is a tough one. I mean, I do think that we as health plans, and to some extent even health providers, are responsible for the financial consequences of how we structure the services and benefits and care that we are tasked to render. And I do think that there's an important barrier, I don't want to say barrier, but we sort of have been running in parallel with the community-based service system, and therefore, frankly, healthcare doesn't understand it. And since most of what we do looks at quote unquote return or quote unquote value, but it's usually dollars and return, it has been very hard to disconnect us from that usual way of thinking. And I do think that we wrestled with that at Healthfirst, but I feel like we took the opportunity to learn through DISRIP, to learn through organizations like RNYC we've known for a long time, and to just finally decide that it is critical for our members to be able to benefit from the service, the care that we have available to them, and that health workers were going to be critical to that journey. However, we can't place upon the back of the health worker system issues, system barriers, inequality, systemic racism, and so on, that they really are not responsible to change nor account for. So our programs are therefore not based on return on investment. That's it. And we have been structuring this so that, similar to David, to the extent that we see need, we try to figure out a partner that's aligned, and we try to figure out if there's a way that we can come to some working relationship, and let our members sort of engage in that delivery system that's community-based. And also, I would also say, because I know Dr. Redding's model pretty well, we do not track every single touch point. We don't track every single intervention or activity that our CBOs do, because they're treating our members as whole people. And it's hard to say that because this RNYC CHW called the member on that day and offered them an air conditioner, I have no idea, that's what changed trajectory. So that's been our philosophy, if that helps.
David?
Nadia, I think at the basic level, Medicaid doesn't pay for it. It's not a reimbursable service under Medicaid. And so, plans are reimbursing for hospitalizations and doctor's visits and medications and durable medical equipment. This is not one of those services. And so I think from a plan perspective, from a business perspective, you say, well, if we're going to add a service, then we should see an outcome that helps the business. And either by improving quality, reducing utilization, controlling costs. So that's why community health workers are saddled with that ROI sort of a question, because everything else, you're correct. Nobody looks at the ROI of a primary care visit. Nobody looks at the ROI of a medication. Often when they do, it's not a very good one, but nevertheless, it's what's required. That's what we are required to pay for, and that's what members expect. So I think that's why you have community health worker programs and other sorts of programs like it under that sort of scrutiny.
I'm just going to jump in and take us in a little bit of a different direction. It's true that Medicaid has all kinds of struggles in terms of covering this work, and rates need to be expanded. And let me just leave that at that, but say this. From the payer perspective, especially when the duration of measuring impact is often misaligned with what we need in the social care sector to measure social change. So if I want to run a diabetes program and I want to show value, I need longer than 3 months. I need longer than a year in order to show the return on the investment, which is why this is really, needs to be a policy discussion. And, it's thrilling to see that with a new administration that there is more of an understanding of this. It is true that the healthcare dollar, in terms of what is covered by Medicaid and not covered, that is a real sort of fight within the plans. And I see people like Dr. Beane, my colleague, wrestling and advocating for this kind of work. I can attest to that. But we need to think about return and value differently. And, some of the sort of milestone things that we can talk about need to be lifted up. For example, in asthma, this is true in the research, this is true in the early days of the metrics that we were being measured by. Absenteeism reduction is a real measure. That's not something that aligns with the way health plans are paid, but it's something that society ought to care about. It's something that we ought to care about. If kids can't participate in school, that's a problem. And we know the sequela related to that problem. Thinking about COVID for a minute, my team has been fully remote, like many of others, since March 16th. We've struggled, but have been able to measure important milestones that we've been able to deliver on in this period of time. We've engaged over 8,000 or about 8,000 New Yorkers in vulnerable communities to connect them to telehealth, to connect them to primary care, to make sure that food could be delivered for food insecure families, to work on their housing challenges. Those are all milestones that community health workers can be measured by. And we need to broaden what those measures and milestones are, rather than just waiting for sort of claims-based, validated sort of healthcare delivery metrics to invest and to make the business case for this work.
I'm just going to pick up on that for one moment, Shoshanah. Do you think that this is an area where cross-sectoral collaboration could help drive some of the lifting of different types of values? So taking the education piece as an example, have you, worked with boards of education or the school system? And is there an opportunity there to kind of tie together, you know, your program's ability to, you know, lower the amount of school that kids are missing with some of your programmatic efforts.
Yes, I think this work, and I think the social care sector really understands this. Nobody has one barrier to health. Nobody has one social need. Nobody has one condition in the populations we serve, especially if you take a household approach, right? If a child with asthma is referred to us, but the adult caregivers of those children are struggling with different conditions, we as community health workers want to engage and do engage the whole family. That is not covered or reimbursed. But that is valuable. And so we have these gaps. And to answer your question, Nadia, I think absolutely it needs to be interdisciplinary, multi-sectoral, and comprehensive. And there is a data component to this, which is real in the way that we live and work now. And that is the interoperability piece, our ability to, for example, in Medicaid, you can't even associate a child with a parent in Medicaid. For commercial insurance, we have a situation where you typically understand what's going on with a family. In Medicaid, that's not the case. And so we need more whole person, whole family interventions that don't miss the opportunity to do more once we have someone engaged, because that engagement is the most difficult lift. It's the most costly lift. And once we have engaged people and we're able to build the trust, we can do so much more. And there are opportunity costs of not doing more once we have that trust in the relationship. So that's what we're looking to build. And absolutely, we need to work with education. We need to work with housing, because all of these things go together.
So I'm going to move us to, there's a host of questions in the Q&A around engaging payers. So Sarah, with your Pathways model, you've noted that sort of collaborative engagement with payers needs to be in place for this to be successful. Susan and David, you've talked about how, you know, you work very closely with your network of community-based partners. Shoshanah, you've shared specific examples. So, and I think our audience is in, they're across the country and they're at different stages. So there are some places where there has been no engagement with payers. There's some where it's been met with resistance. And others, like in New York City, where we have a very payer-rich environment and a lot of collaboration going on, yet we still see challenges to that engagement process. So can each of you kind of speak to that and comment on, you know, how do you engage in payers? How do you get that investment and commitment? And what are some of the sort of best practices in that process?
I can speak a little bit from the hub approach, and it's really important to engage payers early in the process and make them partners, right? Because you have to understand what's important to the payer, as well as what's important to the community, as well as what's important to the healthcare system. It's all important. So to have their perspective in the beginning and to be a partner in the discussion is really important. And I'm going to take us back a little bit, but I totally agree with Shoshanah that it's a whole family approach. And that is really what the hub model, the ultimate model is that once you get a community health worker connected with at least one individual, then that community health worker works with the entire family. And it's up to the hub to figure out how to get funding to support that, whether it's through multiple contracts with payers or private philanthropies or however. That is really the model of serving one person and ignoring the rest of the family will never work. It has to be stabilizing the entire family. So totally agree with that.
You know, Anthem has dedicated millions of dollars to, tens of millions of dollars to address social determinants. But to approach Anthem, to try to sort of become a partner with Anthem on that is, I think, a complicated process. You know, we have both a national company and then local plans. I guess the thing that I think we would look at favorably is how does a community health worker program help us close gaps in what our current services are? And I think I think what Sarah is saying is, and I think Shoshanah as well, that community health workers sort of create multiple opportunities to address social determinants. It's not simply, the funding of a food bank, for example, or let's say providing legal assistance for housing for people with housing problems. I think that's an attractive proposition. How do we? Can you approach us on a local level, or does it have to be national? I think it probably needs to start on a local level in a conversation with the plan leadership itself and saying, what are your priorities, and can we help you meet them?
Susan?
Yeah, I agree with everything that has been that my colleagues have said. I do think that the advice that I give to community-based organizations is a little bit radical, but I'll just say it. I advise them to do everything that David has said and Shoshanah has talked about, but most importantly, understand your worth, not from the MCO's point of view, but from the community's point of view, and base a proposal on that. So Shoshanah just listed all of the value that she provides, not from the MCO's perspective, but from her experience working with communities, et cetera. And I think that if, as David said, you can find a few areas of gap areas that the MCO has or the healthcare system has, and you can say, in my model, we will help you close those gaps, et cetera. That is a starting place. So you have to be able to speak your own language, which is going to be different than our language, and make sure you ask the MCO to keep the people, the clients you're serving, at the center of the discussion. And I feel that has certainly helped us to have a better understanding of, how we might work with community-based organizations. I call it the secret sauce. Like, never compromise your secret sauce, and never let MCOs kind of clinicalize you so that you kind of lose your focus on that secret sauce.
Thank you.
I don't know if that's helpful at all, but.
Yes, no, that was a very practical advice. I loved it. I think it's very helpful. So there's a lot of discussion generally, and in this forum among the audience member, there's a lot of discussion about certification and some of the tensions that exist with CHW certification. Dr. Redding has talked about certification of a program, if I understood it correctly, of the model. Susan and David and Shoshanah are working in a state where there is no statewide certification. So I think CHW's certification varies across probably both your organizations and your programs. So I think, I guess I would just really like to hear your reflections on that. I think we often hear that, CHW reimbursement would be made much easier if there was standardized certification. But I think you've shared examples where it's happened without that. We've seen examples across the country where it's happened without that. And so, yeah, I think if you could all just reflect on the issue of certification. And I'll sort of also, trying my best to lift up the voices in the audience. I think there is a lot of concern that the idea of certification for CHWs in particular really takes away from their core identity and who they are, which is really about connectedness, fundamentally about connectedness to the community. So yes, I think I'll leave it there. It's not exactly a question, but maybe kind of a reflection on the issue of certification.
Yeah, Sarah, I guess you can start because you've done a lot of this work.
Oh, well, and this is such old work now, right? But because Ohio had certification starting in 2004, but it was from our discussions with payers that they basically said, we're not going to contract with you unless you can have some basic criteria around your workforce. You know, we have to know they have a background check before they go into a home. There's some basic things that have to be in place. So we kind of knew that early on, that if we ever hoped to have contracts, we had to pursue that.
For Healthfirst, we have a pretty rigorous process that our community-based organizations have to go through in order to work with us. And through that process, we understand the qualifications of the organization, the kinds of workers they have, as Shoshanah said, the kind of system they have. And once they make it through that process, if they're still willing to work with us, then generally we don't have to be so very concerned about the specific certifications of every health worker.
Mm-hmm. And that process, Susan, is the kind of contracting process, correct?
Yes, yes.
And I think from our perspective, and I think this is true for many CBOs, it's not unique to RNYC, we have learned to develop over the years our own way of kind of achieving the rigor that we require of our workforce. And, you know, I think that we hire people who have the human skills, and then we train up for everything else around that. Yes, we do background checks, and yes, we do all the compliance rigmarole that we have to, and in order to have partners like payers and healthcare delivery system partners. So we do that, and that's the easy part. But the much harder part is the standard we hold ourselves to, right? We are every day, all day, working really hard to support and grow this workforce. So we think of our community health workers as professionals. We invest in their skill development. We think about their career pathways. We, even without certification, try to find ways to grow people and develop people and create a culture of learning. And so we do all of this on our own. We learn together, we train together, we listen to our workforce about what they feel they need to learn to do this work. And I would say that our standards, regardless of there not being certification in New York, are really high. They're really high, and they're high. The highest thing that we are screening for is the mission-driven person who comes into our world to do this work because they care. None of them are paid enough, but all of them are paid. And as long as I'm running this organization, we're going to be continuing to try to fundraise so that we can pay people wages that are fair. This is not a situation where we are contracting people and not paying living wages. This is not a situation where we are asking people to volunteer and be altruistic. This is a job. We take it really seriously. We ask a lot of our team, but I can assure you that in terms of certification, we are exceeding where most of probably even, you know, corporate America are asked to do, because we are asking people to help other people improve their lives. And that goes beyond any rate than any payer or state would pay us.
David?
Yeah, I mean, when I hear Shoshanah talk about what they look for in community health workers, I'm not sure that it even is sort of would be captured in the certification, and I'm not sure that it would matter, at least to Anthem, in places in the country where there is certification. I don't know that we only contract with organizations that have certified community health workers. I think from our perspective, it probably provides more flexibility on our end to contract. But similar to what Susan said, you know, it's hard enough to get small organizations through our contracting process. So I think in some ways it would just create even more hurdles. And I don't know if it would benefit the community health worker organization to have to go through certification.
Mhm. And Sarah, I think there's a couple of questions for you. So places where your program has been replicated, the hub model, does there necessarily need to be a statewide certification in place? Or so you've worked across a variety of different training and certification models?
There's basic requirements of CHWs to be trained, but it doesn't matter whether they have state certification or not.
Great. Luckily, this will be a recorded session. I feel like we need to broadcast this to health systems and policymakers across the country, because I think it's not surprising to us, but it is surprising how often this is the kind of first question that we come up against when we're talking about CHW sustainability and reimbursement of efforts. Okay, so we have.
Can I just jump in one more time on this? This is something that, you know, often when we talk to, this is changing, but, you know, as long as I've been doing this work, sometimes you hear from people from the medical profession, from nurses, you hear questions about the scope of practice, and you hear skepticism about, well, what is the training? What are the qualifications of a community health worker? Yes, you need to learn about disease management if you're doing a disease management program. But the value of a community health worker, which you may have heard me say before, and you will certainly continue to hear me say, and you will hear this tomorrow from the panel of people who are operators, it's really about showing up for people who are disenfranchised, who are marginalized, who are suffering, who have barriers, who have health, who have major issues and need to be connected to care, all kinds of care, need to be, you know, held, need to be seen in this system, in this country. That is, you know, that we are all learning a whole lot more about if we haven't been, you know, paying attention of late. So the value of community health workers is just that. And we will continue to work to try to figure out how to get these programs paid for. But this is a workforce that really, really should not have to prove its value more than it already has, not just in the United States, but in countries around the world, in resource poor settings, where just showing up for somebody disenfranchised and marginalized who doesn't have a voice can make the difference about whether they eat, about whether they get their medicine, about whether they get into primary care or anything else that they need. Thank you for listening.
Thank you, Shoshanah. So we have a really, such an incredibly rich list of questions from the audience, and I've been trying to incorporate them some into our discussion. I think we have about half an hour left, so I'm going to try and go through some of them and collapse some of these into some broad categories. And some of them are really for specific panelists. So Dr. Redding, since you went first, I'm going to start with a few that are specifically about your model. And so I think there's some interest in learning a little bit more about the payment model. So for example, is the hub self-funded, or does it take a piece of the payment of reimbursement? How are you including capitation payment, and what are you seeing in that model versus fee for service? And are there differences in the completed pathways versus the non-completed one? And do you need to engage outside sort of funders for that piece?
Yeah, okay, so.
Sorry if that's too much at once. I'm trying to put it all together.
Let me go back to the first. So give me the first one again.
Okay, first one is just a little bit more about the payment model. So is the hub self-funded, or does the hub take a piece of payment of reimbursement?
The hub takes a piece of payment, and that's why the hub needs to stay very small, because you don't want a huge another layer built in. But the nice thing for the agency that contracts with the hub, for the community health worker, is just kind of, and we've greatly simplified the data collection. That was a lot of feedback we got. There's too much, you're asking us, too much paperwork, too much time, we can't build relationships. So we have totally revamped and greatly simplified that process. But really that's the work then happens at the hub to turn that into a billable form and to get payments to come back to the agency. So that's really the work of the hub, to take that burden off of agencies. So yes, there is a small, most hubs are set up where they'll retain a small percentage of those contracts.
Great. And then a question about handling capitation versus fee for service payments.
Well, it's, you know, our model is outcome-based payment, and part of why we set it up that way, because frankly, community health workers are a lot better at getting to the outcomes than pretty much anybody else. So we knew that if that was the criteria, and that's what we saw when we piloted the first hub, we had all kinds of people. We had nurses, we had social workers, and it ended up with the agencies that had community health workers, because they could actually get people housing and they could actually figure out how to make a family food secure, where the other professions didn't do well with that. So it was kind of a subversive way to get, again, to build the sustainability for that workforce. So, but the outcome-based piece of it, so contracts have to be 50% tied to outcomes. That's, if you're a certified hub, that's required. So those outcomes are critical. And honestly, a good community health worker does great with this model.
And then I think just building on that, how do you cover the cost for the kind of non-completed, the gaps in your model?
So part of in pricing for the completed ones, we incorporate that in. So we've done studies on how likely are you to be successful in getting somebody housing. And so those pathways are worth a lot more than a pathway that we know is going to be pretty successful. So that's one way we do it. But also, again, the hub is going to try to find as many different funders as possible. So again, in Ohio, where we have the Commission on Minority Health, they really fund more of the infrastructure for the hub to help support you know, training and quality improvement and other things that aren't supported through the payer contracts.
Great, thank you. So this next question, I think is probably directed towards Susan and David, but Sarah and Shoshanah, I think you can reflect on this as well. So are the CHWs that are part of health plans getting into neighborhoods and talking to or engaging people who are not engaged in care or not insured at all? So how do you kind of, how do you approach the kind of non-member issue?
We don't. I mean, we are restricted to only talking to our members. I can say that, you know, there aren't instances where maybe someone is approached when they're walking down the street and they're asked questions about obtaining coverage and clearly they can help in that setting, but the primary role is to assist our members.
Yeah, I totally agree with David. You know, our plan, just like David's, will do community activities, some very targeted around specific health needs. That's usually in collaboration with community-based organizations or our providers. Some of those programs can be ongoing as well, but ultimately we do have to focus most of our resources on improving the outcomes for our own members.
So Shoshanah, let me turn that to you then, as an organization that has worked with Healthfirst, right, and has contracted with them. How do you approach that issue when your CHWs are out in the neighborhood and they're meeting a non-Healthfirst member who may have, you know, a very similar challenge? And you know, what has your kind of workflow looked like around addressing that issue, and then how do you kind of meet that challenge in terms of community members who may be uninsured?
I'm going to try to answer that question with a couple of examples of where that gap really can trip us up. One is in terms of providers. So we work with providers throughout the safety net of New York City. And providers, when they're at the point of care or even not at the point of care, if they're asynchronously trying to refer someone to a program like ours with a community health worker or any community-based program, they tend not to like programs that are plan specific. They want to be able to offer their patients, they want to offer people, like everybody, the same program. And so if we have a program, say with Health and Hospitals, which is our safety net system here, we want to, we want it to be easy for providers to refer. And if they have to keep track of, well, this patient has Healthfirst, so I can send them, but this other person has Blue Cross and you don't have a program with them, so I can't send them. That's too much for providers to keep track of, given everything else that burdens them. And so that's an example of where it's an issue. Another example, if you take the case of pest management for asthma, if we are able to, because we have a program with, say, Healthfirst, and we do, offer a family who has mold or rodent infestation, roaches and rodents in their homes, if we can refer them to integrated pest management, it's a great value for them that we can offer through partnership with say, Healthfirst. But we are only able to do the pest management in that one unit, whereas the person probably lives in a building where rodents and roaches are a problem for everyone, not just in that building, but a whole cluster of buildings. So if we were building an ideal, place-based community intervention, we would be able to do integrated pest management for the entire building. It would be more sustainable and ultimately more cost-effective than doing an individual apartment unit for somebody who is lucky enough to be a member of Healthfirst in this case. So those are two examples that really illustrate what happens when we have contracts with specific plans rather than the community-based approach. Or, if you're working with someone in a household whose adult caregiver needs help with something, we're going to try to help that person. That person may not be a member of the same plan, same situation. So there are limitations, but there's also a lot of opportunity once you're able to bring a plan to the table and work it out together.
Yeah, and I think also speaks towards policy opportunities in terms of expansion of coverage.
Yeah.
Sarah, do you want to comment on how your model has addressed this issue? I know you have multiple kind of partnerships with payers, but there are always going to be community members who are uninsured or are connected to different payers that are not part of the hub.
And that is a big function of the hub. So for example, in Ohio, all of the Medicaid managed care plans contract with hubs. So if you're on Medicaid, there's a good chance you'll get coverage, but not everybody is. So then it's reaching out to other funding sources. It could be United Way, it could be local job and family services. So a hub is really always on the lookout for how can we support anybody we come in contact with that might need services, so the community health worker can get paid for that work. I mean, hubs are not always successful, and sometimes we'll be, they do work for free like every other community health worker program does, but we're really trying to find ways to support that work because they need, CHWs need that support and benefits, and they are a professional, and if we're going to retain them in the workforce, we have to support them. So that's a big mission of hubs, is to try to find multiple funding sources to pay for that work.
Great. So there's a question regarding, I think particularly for CHWs that are integrated into clinical systems, how do we build clinical provider buy-in so that they're really asking for the intervention?
I can jump in on that and just say that providers, if we have found in our experience that when we do good work, providers know that and are eager to refer. What we can do to improve integration is make the technological aspects of that and the data management aspects of that easier. It has to be easier to refer people to programs, even within the clinical setting, even within the same setting. There are issues about when we were based at Harlem Hospital, we used to walk down to the floor to be able to do in-person handoffs. That warm handoff is really important. And so, you know, the more kind of relationship building that can happen between community health workers and clinicians, the better. And I think that, you know, having spent some time with medical students in recent years, the medical students and the future doctors really get this. They get social determinants, they get non-clinical factors. And I really am very optimistic that this sort of skepticism about the value of community health workers is in decline. Not saying it's not difficult.
Susan, you're smiling, and I'm thinking about our work in engaging providers.
Yeah. Community health workers in the provider setting is of proven benefit, at least for diabetes. We believe also for hypertension, we believe also diabetes. And I think there's a reason for that. I think what I learned from that work is that if you consider that the client, patient, member is the center of this world, similar to the hub, center of the hub, let's call it, to honor Dr. Redding's work, then you know, it's a balance of power. The health worker pushes the balance of power toward the member or toward the client. We still have not figured out how to bring that model to life. So that's something we're still learning more about and you know, working toward. But you know, absolutely, we know that there is, you know, certainly evidence that chronic illness is improved when a CHW is available at a practice site.
Any other
All
thoughts?
these challenges that we have to work on, everybody.
Well, so I want to point to one sort of note and question that, you know, Medicaid can actually reimburse for CHW services through the preventive services ruling. I think the issue is that there is a process, and we haven't seen that come to scale yet, right? We haven't seen it come to fruition in a widespread way. So, but you know, especially from the payers, but I think from all of our panelists, what do we need? What needs to happen to make that happen? If there is a ruling in place that does provide for reimbursement, you know, how can we ensure that that is utilized more readily?
You know, I do think in New York State, and David will agree, we have to push the state to help us take a more consistent and sustainable approach to working with community-based organizations. We were mandated to do so during the, you know, period of time around DSRIP, right? That was part of the roadmap. However, there wasn't a lot of, I don't want to, guidance, you know, in terms of the phases of getting the CHW community-based organizations, you know, really embedded in the work that we do. So I think part of this is that we do have to push the state, especially around equity, et cetera, access and equity, to really issue some, I don't want to say regs, but, you know, even a task force to be sure that this moves forward. That's one important piece that was missing. David, what do you think?
Yeah, so I'm not familiar with how I think it requires the state to make application to CMS. It's not something that I think that right now is under the purview of the plans. I mean, the plans can offer what they call in lieu of services, but it has to be sort of something in place of a service that is normally provided. So, for example, in lieu of providing, let's say, a community, a in-home aid, you might provide in-home meals as a substitution, if that's preferable to the member. So you can get some other things paid for, but I'm not aware that at this point, the state is allowing us to get reimbursement for that. So I think you're right. It's going to have to be an effort at the state level And, you know, DISRIP really was the opportunity to do that. It really was sort of the opportunity to promote new models of care. And I think that's, you know, it was a disappointment that that did not come to fruition in any meaningful way. And you know, you can talk about why that happened, but I think it made some inroads in creating virtual networks of providers, but I don't think it really was very effective except in some isolated instances of really getting community-based organizations more integrated with the healthcare system.
Right, and neither of the plans represented here are guilty of this, but one of the things that we saw happen in New York was real gamesmanship around the DISRIP requirement for value-based care. We have contracts where not even $1 was spent after lots and lots of time that we were investing to develop programs so that a payer could fulfill a requirement. It was very easy to just work around the requirement that payers contract with the CBO for one condition. So what we need to do when New York State emerges from this current situation, which is dire, is redo this with a lot more teeth, and learn from what we were able to learn in DISRIP and really build on all of that and the importance of including CBOs, including the community health worker workforce, sort of front and center in the next wave of redesign.
Indeed, and I think there are several follow-up questions and suggestions towards that. So, making this a really big policy focus in the coming months, thinking about reimbursement in lieu of health home services with broader eligibility, perhaps. Thinking about billing under MAA or TCM. I'm actually not sure what TCM stands for. So I think we're at 11:50. I'll ask one more question and then we will wrap up. Just a reminder to our audience members that there is going to be a brief poll that comes up at the very end of this panel. So please take a few moments to answer that. I think actually I'm going to take my moderator's prerogative and not go with an audience question, and try to, I think Susan highlighted that there's lots of challenges. We've talked about a lot of challenges. I think for me, what this panel has demonstrated is there's a tremendous amount of opportunity that you've already leveraged and have in place. We just completed a very critical election. I think there are going to be more opportunities for expansion of the CHW workforce. That's our hope. So I think I'd like each of the panelists to just reflect on what your sort of biggest wish is, to advance this workforce, given that there is, hopefully a new horizon.
My wish is, my wish really is that, I think to David's point about lack of real teeth and Shoshanah, I think that more than teeth is injecting funding into the system to gain the benefits of having CHWs and community-based organizations, help our members and families that and communities that are really struggling and who otherwise will not be able to experience the full benefit of the healthcare that is available to them. So that's my wish.
Yeah, I would agree. I think when you look at other types, and Shoshanah brought this up, that in addition to being under this ROI microscope, the time that you have demonstrate ROI is often totally unrealistic. You know, the effects of these programs may only be felt years down the road, and for a for-profit company, our window, our horizon is like 18 months. So I think that if we're going to have an expansion of community health worker services in New York State in the Medicaid program, there has to be a decision by the state to support it, and that it's not simply as a reimbursable service. I think it sort of has to be built into the program. Otherwise, I think you know, the plans, it's going to be very slow in terms of adoption. I think the state has to make a judgment that this actually is an important part of healthcare services and support it.
I mean, I think I've kind of talked about a number of items on my wish list, but really it does come down to funding. I agree with Susan. Funding to pay, grow, scale the community health worker workforce from a community-based perspective.
And I will say funding too, and to move funding away from healthcare towards community. We put so much of our funding resources on the healthcare side and not on the community side, and that really has to switch.
Wonderful. Well, I cannot thank you all enough for this really just excellent conversation in so many ways. You know, I think you forced us all to be very critical of what I really see as your tremendous successes, but that there are, you know, there's a long way to go as well. And I think you gave our audience members and all of us much to think about as we work to advance this workforce. So thank you, Dr. Redding, Dr. Beane, Dr. Ackman, Shoshanah Brown. Thank you for participating today. And I think most deeply, thank you for the work that you do for supporting the community health worker workforce. And I know each of you would really extend your thanks to your CHWs for, you know, the really on the ground, to the ear, people person effort that they put out, you know, at every moment. And, you know, I'll just, the same goes to the CHWs that I've had the pleasure of working with. So, you know, I know there's been lots of questions about whether slides will be available in recordings. We will hope to make that available. There's been some requests for participant panelists information. We'll make that available with the permission of the panelists, as well as some literature that was cited throughout. So again, with permission of panelists, we'll make all of that available. A reminder to join us tomorrow, November 12th, for day 2 of this Innovation Summit. I mean, I think we've set ourselves up for a really tremendous day 2. Our first panel is on navigating upstream and downstream, the role of community health workers in chronic disease management and prevention. This panel features community health workers from various programs and jurisdictions across the country. And we're, you know, very much looking forward to hearing directly from the leaders in this workforce. And that will be followed by a panel on public systems leading the way, CHW initiatives at the nexus of public health and health systems. So really hearing from health departments, from health systems about how they have engaged this workforce in their efforts. There is a link, I believe, in either the chat or the Q&A. We will send it out again. If you need to register, details on the agenda are also at the registration link. Again, thank you. It's really been a pleasure. You know, I've been watching the audience members virtually, many of whom are friends and colleagues. I'm sorry that we can't see each other in person or even virtually, but it's been really heartening to see you here and to have you engage so actively in this conversation. So thank you again. Virtual round of applause for everybody. And please do stay on for a few moments to complete the poll.